Welcome to this practical pharmacology course designed for working out of hospital. Rather than just taking this one drug at a time, I've designed the course around different scenarios. So our very first scenario is going to be on postpartum hemorrhage. Now, a little caveat, this scenario doesn't cover everything there is to know about postpartum hemorrhage. It just provides context for management of postpartum hemorrhage using the medications that we're going to cover. So don't expect to learn everything you need to know about postpartum hemorrhage by watching this particular scenario. The protocols discussed in this scenario are based on the latest recommendations of the World Health Organization, WHO, and the International Federation of Gynecology and Obstetrics, called PHIGO. Their recommendations are designed for a variety of different delivery settings in many different international locations, including low resource, low tech settings. So we may be talking about a couple of drugs that aren't even available in the United States. Those drugs will be dealt with very briefly, but I want to make sure that you know all of the drugs that are covered in the different international protocols. So having said that, let's begin by reviewing the most current definition of a postpartum hemorrhage. A lot of us are used to what was true for many, many years, which is that a postpartum hemorrhage is 500 milliliters of blood loss, which translates to about 2 cups, after the birth of the baby. So that has been updated, and now the definition is greater than 1,000 millimeters of blood loss within the first 24 hours after the birth of the baby, or more than 500 milliliters of blood loss with signs and symptoms of shock within 24 hours of the birth of the baby. Notice that that does not include any antepartum bleeding. However, as a practitioner, you need to be aware if she's losing blood before the baby is born, then you need to count that also in your calculation about total blood loss. Also notice that it's after the birth of the baby, not the birth of the placenta. So officially, you're still in labor until 3rd stage delivery of the placenta has occurred, but for purposes of calculating postpartum hemorrhage, you're counting from the time the baby is born, not the birth of the placenta. So, having gotten all of that out of the way, now let's look at our scenario, so we can apply this information. Being aware that it is very crucial when you're managing postpartum hemorrhage to really keep up with how much blood she's lost, the best you can to measure and get that figure accurate so that you're not over or underestimating blood loss, particularly with this new definition of 1,000 mils without signs and symptoms of shock. You want to not be underestimating your blood loss before you realize that you're looking at or approaching a postpartum hemorrhage. Okay, our scenario. Our client's name is Nabila. She is 28 years old, a Grava 3, Para 1. Her pregnancy care has included extensive nutrition education and support, supplementing with iron and vitamin C to support the iron absorption, and a diet with sufficient protein, calories, water, and salting to taste so that her blood volume increases to a healthy level and she has a healthy pregnancy. Her hemoglobin at 30 weeks is 10.8, which is the peak of hemodilution in pregnancy, or the nadir for your hemoglobin levels. At 36 weeks, she's improved to an 11.6, and she is GBS negative. Her pulse was 92 at that visit, her blood pressure 128/68, and went ahead and took her respiratory rate, and it was 18. So she's well within healthy normal bounds for her vitals. At 38 weeks, you check, and her hemoglobin is now 11.9. So you're feeling really good about Nabila. As part of your informed choice conversation at around 35 weeks, you discuss postpartum hemorrhage prevention, including recommendations by WHO in 2018 and by PHIGO in 2022 for preventing postpartum hemorrhage by using the newly defined active management in 3rd stage. So when you're talking to Nabila, you talk about the following points.